Good afternoon, everyone, and welcome to the New York SIP COVID-19 webinar. Thank you so much for joining us this afternoon. We are going to give everyone just a few moments to log on. We will be starting the call momentarily. Good afternoon, everyone, and welcome to the New York State Society of Interventional Pain Physicians COVID-19 webinar. We are very glad you are here on the call with us today. We will start the call in just a minute. Good afternoon, everyone. Thank you for calling in to the New York State Society of Interventional Pain Physicians COVID-19 webinar. We truly appreciate your joining the call. The call will begin momentarily. Good afternoon, everyone, and thank you for calling in to the New York State Society of Interventional Pain Physicians COVID-19 webinar. I would like to introduce Dr. Sudhir Dewan, who is the moderator for the call this afternoon. Please note, if anyone has a question, there is a chat box on the webinar to your right. Please pose the question and do let us know where you are calling in from, just in case the question is more regionally specific. Again, welcome to the webinar. Thank you for calling in, and Dr. Dewan, take it away.
Hello, everybody. I'm Sudhir Dewan. I'm practicing in New York City, and we have put this webinar together just to make sure that we all stay connected. We are going through some very difficult times. This is situation of the pandemic COVID virus. I don't think anybody ever has seen or even imagined. So it's a tough time, and let's all work together and try to do our best. The society's kind of activities are all disrupted. Our lives are disrupted. We are following this strict criteria of the self-distancing, and hopefully we are not isolating and stay connected. We have excellent team of panelists, and I will start introducing the first speaker, who is Dr. Christopher Garibo. I'm sure Dr. Garibo, you all know him. He is a professor of anesthesiology and pain medicine at NYU. He is our former president of Nysipp, and he's a very, very active in Nysipp and New York, New Jersey pain symposium activities. Dr. Garibo, you can take over.
Thank you, Sudhir. It's an honor to be here before all of you. I think it's a particularly and in many ways spectacularly stressful time for all of us, especially for the practice of pain medicine. We never thought such a thing would happen in our lifetime, but it actually did, and they'll be writing about this epidemic 100 years from now when we're all gone. But I think this is a practice that has been hugely impacted by the COVID-19 pandemic from a pharmacological perspective, from a interventional perspective, as well as from a financial survival and pain practice management perspective. Now, we're not going to go over the symptoms and signs of COVID-19, but I have this presentation here to you, particularly this slide, to basically demonstrate that many of our therapies are actually related to the COVID-19 symptoms. For example, we prescribe antipyretics in the form of anti-inflammatories. Many medications that we prescribe may cause somnolence, fatigue, altered mental status, which may be associated with COVID-19 due to the fatigue and altered mental status that hypoxia may cause. We prescribe opioids, which are anti-cough medicines. We may prescribe other agents that may cause dry mouth. And so there is a potential for masking of the COVID-19 symptomatology with the pharmacotherapy that we engage in, whether if it's anti-inflammatories or opioids or anticonvulsants, or really just about any type of medicine that we prescribe, including, for example, transdermal medications that may have altered absorption as a result of the fever and changes in skin blood flow associated with COVID-19. Of course, COVID-19 affects us in our practices in many other ways than just from interaction with the pharmacological agents that we prescribe. Dr. Durkin is going to get into, for example, the interventional aspect, but there's a logistical aspect here that we need to focus on here as well. We're all trying to minimize person-to-person visits, in-office visits. We're trying to mitigate travel as much as possible. We're trying to flatten the curve. People are off the streets. Patients are not coming into our offices. Certainly our metro area, and particularly New York City, is hugely impacted, and telemedicine is now a big part of our evaluation and management strategy as opposed to in-office visits. And so I propose to all of you here to basically telemedicine as much as possible. There may be a subset that you may still need to see, let's say for a pump refill or for chronic opioid therapy, but let your telemedicine visit, that E&M visit, serves as a screener for your office visits. And during that telemedicine visit, you can also, if the patient needs to come in, you can screen them to see if they have any acute illness or not. Because if they have any flu-like symptoms, they should not be coming to our offices. They should be following up with their primary care doctor or some other suitable clinician that can follow up with their COVID-19-like symptoms. We can also protect the vulnerable patients, those patients that are elderly with concomitant disease, hypertension, other cardiac morbidities, or any other type of end organ dysfunction, diabetes, those with history of cancer, chemotherapy, should also stay home. And we should try to telemedicine them as much as possible and keep them from traveling and being exposed to the to other individuals and other elements that can predispose them further. As you go about scheduling your outpatients, there is a subset that needs to come in. It's very small right now, but for those of us that are seeing, let's say, 30, 40 patients a day, even if 5, 6 patients came in, it's important that we don't bunch them up. We got to space them out in time, and we got to space them out once they show up at the office, maybe one patient for half an hour or for an hour, just so we respect the social distancing that is being advocated by our governor, by our president, and so on and so forth. So, and if a patient does show up who is symptomatic in the waiting room, they need to be isolated and asked to leave. A patient should not be exposing our staff, ourselves, or other patients to their symptomatology in the COVID-19 era. It's important that we err on the side of absolute caution as much as possible, such that we stop the transmission of this disease to ourselves, other patients, and the colleagues that we work with. Of course, this presents a variety of challenges, medical legal challenges, patient abandonment. It's important that we return the phone calls and use the telemedicine as a stratifier, as a screener. Who needs to come in? Absolutely needs to come in, not electively, not strongly electively, but it needs to be emergent. It doesn't need to be an emergency. If it's an emergency, they need to go to the emergency department. But if it's an essential visit, it can be it can result in an in-office visit, and that maybe that can result in a procedure potentially if it's absolutely indicated. Let's say a patient with an acute disc or somebody with lumbar sympathetic reflex sympathetic dystrophy and needs a lumbar sympathetic block. A very small subset can be considered to receive interventional pain management. In going about prescribing our medicines and our treatments, it's important to stay away from treatments that are non-pharmacological, but that result in multiple other person-to-person interactions. So that may be acupuncture, physical therapy, biofeedback, anything that requires multiple office visits or professional to patient visits should be minimized in the current COVID-19 era. As we go about prescribing, of course, we prescribe a whole spectrum of pain medications. Non-steroidals have come under some degree of discussion within the COVID-19 pandemic. there's really no good evidence that associates ibuprofen or other anti-inflammatories with worsening of the COVID-19 symptoms. And certainly oral steroids also are quite commonly utilized by many pain clinicians and by many other non-pain clinicians as well, as in an attempt to, for example, catch the flare-up of CRPS or catch the flare-up of an acute disc, is something that we commonly describe that we need to take a second look at in the current climate of the COVID-19 pandemic, ripping through certainly our part of the country, but it's going to continue to do so in different parts of the United States as well. So here, basically, we're balancing the analgesic effects of our therapies, let's say such as anti-inflammatory or oral steroid, against the adverse effects of the treatment, specifically pure steroids, and whether if they're affecting the individual's capacity to fight COVID-19. Are we immunosuppressing them? Are we making their diabetes worse? Are we making them more vulnerable? It's something that we need to keep in mind going forward. Both anti-inflammatories and oral steroids are associated with dose-dependent immunosuppression and increased risk of infection, particularly pulmonary infection, and this applies to a lot greater degree with oral steroids, particularly at over 40 milligrams per day. As we mentioned before, for example, anti-inflammatories are antipyretic. You may feel great after oral steroids. Many of your flu-like symptoms may resolve with oral steroids, and you may actually delay out the potential diagnosis of COVID-19 because you're energizing the patient with your oral steroids. You're taking away the inflammation to a certain degree. They may be able to feel a lot better. Some of their fever may dissipate. Some of their myalgias and fever symptoms may dissipate, and they may not visit the emergency department. They may not contact their primary doctor as a result of the anti-inflammatory and the pure steroid. So something to keep in mind. This is a time of great concern and great surveillance where we want to catch and isolate those patients with COVID-19, whether if they're symptomatic or not, or preclinical, so that they can be aware of what they have and keep what they have from being transmitted to their loved ones and to potentially us and our colleagues and our staff. So oral corticosteroids in particular should not be prescribed in symptomatic or asymptomatic individuals if a patient is COVID-19 positive because of the immunosuppressive effects of the oral steroids at significant dosages of greater than 40 milligrams. It's always a balance. Of course, we don't want to go the opioid therapy route either. We want our patients to provide, we want to provide them with clean pain relief with interventional pain management. Many medications have end organ costs and other end organ concerns. And as you saw in the prior slide, COVID-19 is not just a respiratory disease, but it's also cardiovascular disease. It's also gastrointestinal disease. It's also a renal disease. It's also a circulatory disease. It's really a virus that goes beyond the flu-like symptoms. It's not just the super flu. It's way beyond the flu with a whole range of end organ complications, and the anti-inflammatories that we prescribe in particular have significant end organ impacts. Just the fact to keep in mind that sometimes maybe interventions are the better way to go rather than providing for pharmacological pain management, and the underlying concern should be that are we treating somebody who also may concomitantly have COVID-19 symptoms, and they're presenting to you with myalgias and back pain that are a little bit worse than usual, or they are COVID-19 positive, not symptomatic, and are we immunosuppressing them? So with that, I do think that, you know, when I looked at the literature, it really isn't just much in the literature. I will tell you that the immunosuppressive effect is much greater with oral steroids at greater than 40 milligrams. The immunocompromise occurs right away within the first 24 hours of the administration. There's leukopenia that develops within several hours, onsets within several hours of the oral steroid administration, and peaks at about 6 hours or so and resolves in about 24 hours. So a Medro dose pack, prednisone 10 milligrams QID, all elevate the risk for our patients. And acetaminophen comes up as an option, but the bottom line is acetaminophen is not going to be useful for the vast majority of the patients in our practice. There's lack of efficacy, there are hepatotoxicity concerns, But really, the main reservation about acetaminophen is that it's not going to be effective in the chronic subset.
Thank you, Chris. This is really very, very good presentation. We will get the questions at the end, but I have one question for you. In this dilemma where we are not really very sure which one is elective procedure and which one is the emergency procedure, and we are really struggling to make a decision where from governmental point of view you are not violating. So tell me which you think, if somebody has acute herniated disc, what would you do? Patient cannot stand, patient cannot walk, and he wants the either injection right away. Just give your answer in 30 seconds.
I think we need to make sure that we're treating them conservatively with oral medications and home therapy as much as possible. But if it's something that they've had great response to in the past and now they're recurring with the same symptoms and other medicines have not worked and they're not functional, they can't sleep, they can't walk, they can't survive due to their pain, I think an injection would be reasonable at that point.
Yeah, I think it's a very good answer because it ultimately comes down to the physician's decision and has to decide whether this patient requires emergency injections or not. Thank you, Chris, very much. We will get back, regather at the end of the session for the question answer. Thank you very much.
Yep.
It's now my pleasure to introduce Dr. Durkin, Brian Durkin. He is our current president of Nysipp. He has multiple practices in Long Island. He is very well written, very well spoken. He's our regular speaker at New York Pain Symposium, New York, New Jersey Pain Symposium. And here is Dr. Durkin.
Hi, thank you, Dr. Dewan. So on my last note, I actually this morning did an epidural, a lumbar epidural on a patient who last week was supposed to have a discectomy done and got canceled because of the current events. And he had been on opioids, he had been on oral steroids, and I had to weigh the risk of putting him on more oral steroids versus giving him a shot, which in my experience and according to the literature works a lot better than giving somebody oral steroids. So he came in barely walking into the ambulatory surgery center this morning, and he walked out on his own and got into his car to go home this morning. So there are examples, which I'm going to talk about here, of appropriate injections that we should still be doing. So I've spoken to a lot of people over the last couple of weeks in our field, and to gauge what everybody's doing out there. And I've gotten answers that I'm sitting on my couch and doing telemedicine and not even going to the office, to what we're doing here in my practice, where we're seeing maybe 1 or 2 patients a day that need to be seen, for example, for a pump refill, and mostly doing telehealth otherwise, and then doing a few procedures a week on people who really need them. So the first thing that we look at is, first we want to stay on the right side of the law. The governor came out and said that we're going to break procedures down. We're going to stop doing elective procedures in the state, but not everything we do is elective. We do some urgent and semi-urgent, and there are emergent cases that we'll encounter. As non-surgeons, we don't really treat the emergent cases, but we are oftentimes there to facilitate them. Perhaps an epidural hematoma that needs to be addressed that oftentimes is missed by some of the staff in the ER, for example. If a patient had an implant and had sudden onset of neurological symptoms, those patients need to be directed to a surgeon for decompression. So those are things to keep in mind in the emergent area. So ASRA came out with these guidelines this last week that I think are pretty good to follow, and those are available on the web, where they've broken down procedures into urgent, semi-urgent, and elective procedures. Where we're talking about non-elective procedures that are urgent or semi-urgent is like Dr. Garibo spoke about, intrathecal pump refills. We have to fill those pumps up, or it's going to be a problem if we can't fill our pumps. So those patients are being filled in our offices. If they can be done at home, there are options to set patients up with basic home infusion or other infusion companies to get pumps refilled in their house. And we do have patients that are doing that. If you get an infection, that's an urgent issue that can be treated with antibiotics shortly, but those may be needed to be operated on, and those are things that need to be done in an operating room. But where most of my focus has been over the last week and a half since these new rules have come out is on these semi-urgent, which aren't really elective cases, like the case I described before, where the guy had the herniated disc and was going to have surgery scheduled last week, got canceled, and the guy can't function. What we don't want to do is have a patient laying on the couch for the next 4 to 6 weeks, getting a DVT, getting a pulmonary embolism, and being in the emergency room. So our goal as interventional pain physicians should be to, for the greater good of our patients, to keep them out of the ER, where it's much more dangerous for them to be at this point in time. We want to keep opioid reduction in check, and just jacking somebody up on opioids is never been a good answer. And we want to keep people functioning so they're able to take care of their activities of daily living and not become at risk for being incapacitated on a couch somewhere in their house. So those are the things that we're worried about when we're looking at patients that we may be doing a procedure on. I had a lady scheduled yesterday on my schedule in the office for intercostal blocks. So I was going to do them on her ultrasound. She had intercostal neuralgia, and it got scheduled a few weeks ago, and she popped up on the schedule yesterday. I said, no, we're not going to do that. And the reason I'm not going to do that is because, what happens if I drop a lung, right? I'm going to have to send the patient to the ER. So I'm not going to do anything in my office that's going to have any chance of having to send the patient to the emergency room. So that limits many things that we do, and we got to keep that in mind, I believe, as well. So speaking of the side of service, we're not really going to do anything in the hospital. In my case, we have an ambulatory surgery center that's still open for these non-elective pain procedures that we need to do, so we can keep that in mind. And in your office, like I said before, you could do pump refills. You might do a trigger point injection if that might help somebody. That's going to be a low-risk procedure to do in the office. We have got to remember to we really want to conserve masks and gowns and gloves. And many of the things that we do don't really have much of an impact. A pair of gloves and a mask that you could use the whole day, I don't think is going to make a big difference in the overall scheme of things. So areas that we can look at for doing interventional procedures, like I said, the acute disc herniation patient or subacute disc that can't get surgery, that probably need surgery at some point, we might be able to buy them a few weeks over the next several weeks that are most likely not going to result in a surgery being done. A patient with severe headaches, we might want to do some occipital blocks in the office. Those are pretty safe to do under ultrasound. Other local blocks that can be done, as well as a patient that comes in with severe zoster, we can do nerve blocks in the office there. Patients with early CRPS might be better to do a stellate ganglion block on them to get them from being, especially if somebody's in a treatment plan, because their physical therapy has now become a problem getting people into physical therapy. So if we can do a stellate ganglion block in the office, I think that's something that should still be done. And then patients with intractable cancer, we really got to keep these people comfortable and able to be more comfortable in their last days in some points. I just want to say that we at this point on Long Island aren't really, and it's getting there day by day. Each day tends to get worse, and there may be a point in the next week or two where we're hanging up our interventional pain stuff and going and do critical care medicine. We don't know. Time will tell. But until that time comes, we still got to take care of our patients that need us, and for the better good for everybody, keeping them out of the emergency room should be at the height of our consideration. Remember a story my dad told me many years ago regarding World War II, and we're kind of in World War III right now. World War II, my grandfather, I asked my dad where my grandfather was during the war, and was he in the Army, the Navy? Was he in the Pacific or in Europe? And he said no, he was a New York City policeman. The New York City policeman, or any policeman for that matter, fire department, they didn't go to war because they had a job that was crucial to the people that were here. And that's kind of like, I think, where we're at right now. We need to maintain our practices and take care of our patients, and let the critical care doctors at this point take care of the critical care patients. But it may become the point soon where we have to drop our needles and go into the hospital. So one question
Dr. Durkin,
is
Dr. Durkin, thank you so much. Your presentation was very, very helpful. And we are very fortunate to have a specialist, Dr. Neha Kulkar. She is infectious disease specialist. She is coming from the Albany area, and we are fortunate she took time from her family to help us and answer some of the questions. And before we get the question, I would like to hear her presentation. Dr. Kullar.
Thank you very much, Dr. Dewan. First of all, I'm honored to be here. Thank you very much for the invitation. So briefly, what I'm going to be discussing is how corticosteroid joint injections may be influencing COVID-19 at this point. So as the previous presenters have already excellently explained, there is a need for corticosteroid injections in these chronic cases and very severe cases, not only to offset them from going into the emergency room, but in order to control their pain at home, especially with those chronic cancer patients, rheumatic patients, things of that nature. But what does that mean? Obviously, since this is a brand new novel virus that we don't have much information on at this point, we can only use previous data. The most recent the most recent study that I could find was this one that's listed here on the PowerPoint presentation, which only assessed corticosteroid injection with influenza risk. The reason why this was done, at that time is primarily because we wanted to know, I'm sorry, I'm having a technical issue here. Okay, we'll do it on the fly. There we go. So basically, they performed the procedures on vaccinated patients, unvaccinated patients, and the main thing that they were following was to see what the influenza risk was pre and post corticosteroid injection. What they found primarily was the fact that they did see an increase with corticosteroid injection in the rate of influenza. So what can we take from that? So we already know that there is some form of immune suppression that is suggested with steroid injections in general, much less than orally. But most of these infections in the viral world haven't really been studied or haven't really been the focus, as the majority of these infections were attributable to most bacterial diseases. So overall, the incidence of infections associated with spinal procedures and overall large joint procedures remains exceedingly low, with bacterial infections primarily being controlled with proper injection and infection control practices. That also is perceived amongst most of the group of being rare as well. So what does this mean in terms of COVID? So basically what we're saying here is chronic pain patients may be on oral steroids, they may be received in a recent steroid injection, we already know that from the previous study that just discussed that it can be associated with a higher risk of influenza. So what can we do here to mitigate that? So you can use less immune suppressing steroids where the duration could be more shorter acting. So all at this point that we can do is extrapolate the data and basically discuss our options with our patient. So this circumstance, although there's no evidence to suggest that corticosteroid injections result in a substantial increase of risk of infection with COVID-19, there is a possible reduction in the immune response for up to a few weeks following the procedure, if we extrapolate from the current data.
So we actually also have, Dr. Kullar, we also have a lot of questions regarding the use of NSAID. I have a very good question from Dr. Tim Deere for Chris, but I think this is right time, right appropriately you can answer that. Is there any data for NSAIDs conclusively whether we should use it or not? And what about the topical diclofenac gel or oral Mobic?
So as of right now, in terms of NSAIDs, the WHO did publish at one point, based on only one study at that point, or arbitrary data. And after further discussions with the rest of the experts around the world, it was found that NSAIDs are safe. It's not, if somebody is chronically on NSAIDs at this point, it is not advised to take them off. The concern in terms of COVID with NSAIDs and antipyretics is primarily because of the fact that you want obviously not to mask the disease. So that's the main issue in that regard. So someone could be COVID positive and ending up in your office, and you may not know that they have a temperature. So that is something to keep in mind prior to doing any type of procedure.
But you still believe that topical would be better than the oral?
Yes. At this point, you want to minimize anything that could interfere, you know, at that point. The other thing to keep in mind is that obviously any interarticular type of injection would be less immunosuppressing than anything that you could give a patient orally.
All right. Thank you very much for your participation, your help, and your advice.
Absolutely. Again.
Now we'll move to our next speaker, who actually is here taking his time from his family time. Adam Guttel. He is a lawyer. He will give us some legal advice. He's principal in the Long Island, New York. His office is Office of Jackson Lewis, and he practices and focuses on representing employees. So I think, you know, in this difficult time when we have to lay off or furlough our staff, Adam's advice is very, very critical at this moment. So thank you, Adam, for joining us, and please take over.
Thank you, Dr. Dewan, and thank you to Nysipp and Dr. Rubin for inviting me today. I am the one lawyer presenting today. For that, I apologize, but I hope to provide some useful information to you. I am with the Long Island office of Jackson Lewis. We are one of the larger labor and employment firms around the country, a national firm, and all we do is represent employers. We don't represent the employee, we only represent the employer. And in that context, we advise on situations involving, I think the slide just went backwards. If someone could help advance to the first slide. Situations involving the workplace and how to manage your employees. We have seen a tremendous uptick considering the current pandemic. And there are sort of three topics that I want to talk about today. And my contact information is on the slides. You know, a lot of times it takes a longer conversation to answer questions, so I'm happy to communicate with people outside of the presentation today. If you have questions, feel free to reach out. The first issue is layoffs and furloughs. If you have a practice right now and you're operating, but you have to limit your staff and you have to cut operations, you have options. And what you don't want to do is panic in this period of time and do it the wrong way. There are different situations. You can lay people off, a full termination. Those individuals can be free to go get unemployment. I'll reference what in the third slide, what benefits are available to those people. Or you can furlough. And furlough has a similar effect of a layoff, but what it does is it limits, it gives a ray of hope to the individual employee saying, look, we're gonna furlough you for a period of time. We're not gonna do this indefinitely. A furlough by definition can't be more than 6 months. The hope is that this is a situation that does not extend in that time period. I see clients currently furloughing people for 30, 60, 90 days. And you have to document it. You have to provide correspondence to your employees saying, look, we're going to furlough you for this period of time. Furlough allows you sometimes, depending upon with your benefits providers, to continue providing healthcare insurance to your employees if you're going to do that. Furlough is also involved when you reduce people's hours. You know, if someone's working 40 hours a week and you're dropping them down to 20, gives them the ability now to go apply for unemployment. They can get those benefits. They're not drawing a paycheck from you. But they are told that they're no longer to be working, and that has to be very clear. And if you're doing a furlough or a layoff, the issue is the WARN Act. If you have more than 50 employees in your practice and you do a layoff, there are certain hoops you have to jump through with what's known as the WARN Act, the Worker Adjustment Retraining Notification. Typically, you have to give 90 days notice to employees to do that. That may not be practicable now. This is an unforeseen circumstance. That may be waived, but you have to provide notification to those employees and to state representatives that that is the reason you're doing what you're doing. If you don't do these things, there are fines and penalties and potential lawsuits that can follow. So this is some good planning at the outset, because based on the questions we've been getting over the last 2 weeks, and that's all and my colleagues have been doing, is fielding these questions from clients, new and existing clients. There is going to be an avalanche of lawsuits, we think, when this eventually is over, because people are panicking and they're not doing things the right way. A little bit of prevention now will prevent a lot of liability and a lot of risk on the backside. If you are keeping people, you're not laying off or you're furloughing, one thing you want to consider is, who are those people? Are they hourly employees? Are they exempt salary employees? If you have physician employees in your practice who are subject to contracts, if you're reducing compensation, are you breaching their contract by doing that? You have to enter into a new contract. It doesn't have to be a full-blown new contract. You can do an amendment. If the question is, I don't have enough work for you now, I can't continue to pay you, but I can have you work half-time, but we're going to reduce your compensation. Don't just do that, because there may be contractual liabilities from doing that. Another issue is if you're reducing people's pay, whether they have a contract or not. New York State requires certain notification that has to go to that employee if you're reducing pay, whether they're an hourly employee or an exempt salaried employee. You have to give new WTPA, Wage Theft Prevention Act notices under the New York labor law. Failure, if you have a big practice and you don't do that, there's a $5,000 penalty for incorrect or improper wage notices. And there will be plenty of plaintiffs' attorneys, the folks who don't do what I do, but who are on the other side representing employees, who are more than happy to bring a class action, who will bring a lawsuit, just for those nominal violations. New York is a very tough state when it comes to complying with all the letters of the law. Now, for those existing employees you have, there are new obligations. About 2 weeks ago, Congress passed the Families First Coronavirus Act. I will tell you that there is no regulation yet. It's legislation. It's been passed and signed into law by the president. Usually these laws come along with regulations that get passed later. Those are not done. They've been issuing guidance, or FAQs, on the Department of Labor website. There is an FAQ that says healthcare providers are exempt from complying with this particular law. It's a particularly onerous law. However, the FAQ also says that you should be judicious in exercising that exemption, because the goal should be to try to avoid the spread of the coronavirus. What this law does is two aspects to it. One is an expansion of family medical leave. You're all familiar with the Fmla Act. That usually applies to employers with 50 or more employees. In this case, it applies to every size employer, and it applies in situations where you have an employee who cannot work because their child, either their school has been closed or they have no child care available to them. You now, as the employer, are obligated to provide up to 10 days of unpaid leave to that employee. You're also obligated to provide additional paid leave after those 10 days run out, up to a maximum of $10,000 with a cap of $200 a day. That ultimately can be a burden for Long Island employers or New York employers and New Jersey employees, where they've basically shut down the schools. There's the second aspect to this law, which is the sick leave provision. With the sick
Adam,
leave,
very quickly, for the interest of time, I have a very good question for you about this loan and loan forgiveness. Can
yes.
you go just answer, if I lay my staff for an entire period of this crisis, or I furlough them, how this loan or loan forgiveness can be used?
Excellent question, Dr. Devon. And I know that Dr. Chapman is going to be speaking about the details of the CARES Act, which is where you can get this loan forgiveness. But the employee aspect of that is to calculate what loan you're going to get. Has to do with, you do a multiple. It's 250% of your average monthly payroll salary, or payroll, for the period of February through June of 2019. There's a different calculation if you weren't in business back then, but essentially that's it. That is the amount of money that they're going to consider, the SBA and these lenders will consider giving to you. The loan, the money that you can use in that loan, does not have to be used until you get the money, and that would be on the first day of origination, right? So you apply for the loan, you get the money, that loan is considered originated on the day you get that money, and then you have to spend it within the 8 weeks that follow that day. So I know everyone's talking about rushing out today, and I can tell you anecdotally, I've heard from colleagues and clients that systems have broken down. Some banks are not up and running yet. This is something that's going to take a couple of weeks to sort of work itself out and unwind. So you may not be getting this money for a couple of weeks or a month or so. It doesn't start to count until you get it. You get it, and then you have to use it within those 8 weeks, and you have to essentially spend it on payroll and some other business expenses like rent, mortgage interest, utilities, but in the same manner as you would have in that prior time period in 2019. When the government then looks at your forgiveness application, that's what they're going to compare. Did you have the same number of staff members? Did you have the same size payroll? And that's going to determine what percentage of that loan is ultimately forgiven.
In other words, the amount that applied for the loan is different than amount that can be spent for the practice. In other words, you may not be able to include your rent into the amount for the loan, but when loan is approved, you can use that amount for the rent, correct?
That's right. I mean, I think the thinking is, and we haven't dug into the legislative history yet, which we can, but the thinking is when you take 250% of your average monthly payroll costs for a given period of time, and you spread that out over 8 weeks, that extra 50%, so to speak, is that buffer that you could, they expect you would be using for rent and utilities and things like that. You have the ability to spend it, but then they're going to do a different calculation when they look at the forgiveness. Some people are going to get 100% forgiven. Some people are going to get 80% forgiven. And then the remainder gets reset to a loan, a 10-year loan with a fairly low interest rate.
Thank you very much for your great presentation. We will have some time at the end for question and answer. And for now, we will move to the next speaker. Thank you, Adam, again.
My pleasure.
The next speaker is Dr. Chapman. I'm sure everybody knows Dr. Chapman has been quite well known in his work about neuromodulation. He is our president-elect of New York State Society of Interventional Pain Physicians, and he will talk about CARES Act and other very important aspects of that we can use in this difficult situation. Dr. Chapman. Take over, Dr. Chapman.
First, I'd like to say thank you, Dr. Dewan, for having me here. And thank you for the prior talks. I learned something on each one. So, I always tell our physicians we work with to not make decisions based on money. But, my talk here is just really all about money and what's available to us as physicians, and what can we do to get access to that. So the CARES Act, actually, Sudhir, there was a slide before this.
Okay, Michelle, can you go? This is the slide we have after this.
Okay,
maybe
that's
after
right.
this.
Can you go? There you go. So there's two really, what is available to us are two different things. The first one is the potential for a $10,000 grant. Excuse me, it's actually a loan. And that's made available as a one-time payment as a loan. However, if you meet certain criteria, you do not have to return that money. So this is something that needs to be applied for quickly, because there, and before I get into that, the previous slide I was going to talk about was who this is for. And this whole, the CARES Act is about the employer and the employees and keeping employees, and was created essentially to keep people on their jobs. So anybody that is that owns an LLC, a PLLC, any corporation of any type for any reason can apply for this. The money is a one-time payment, and this is applied for online. So at the SBA website, you'll find this, and you can actually look, if you go online and you look at just YouTube, $10,000 loan, it's there. And so you can learn how to get access. The problem, though, is that, with the grant, they, within the CARES Act, they set aside I believe, $10 billion for this. So, all right, $10 billion, $10,000, that sounds like, there's a lot of this money out there. There really isn't if you think that, you know, there's 300 million people in the United States. There's something like 30 million small businesses, and then another 10 to 15 million sole proprietors. What that basically means is that, you know, if there's 300 million, there's going to be 1 million of these grants given out. So there's, at the price it is, there's going to be 1 million given out, and you have 45 million corporations. So you can go online after this if you have a company and submit an application. But again, you have to have a company. So next, the other option available is the Payroll Protection Program, also known as, also is really the SBA loan. That's for the corporation. I don't know who's clicking anything, but it left my screen. Okay, sorry about that. So this part is a forgivable loan, and not low, as you can see on the slide there, for an employer to keep their employees. So if you have employees and you have a corporation, this money is meant for you to keep your employees, keep people having a job for 8 weeks. So this one you have to submit a larger application for, and we're going to discuss what's involved in that in a couple of slides. And the next, the unemployment benefits, that was changed as well, but we're not going to talk about that. So when it comes to, I told you that the initial loan, the $10,000 grant, was through, you can get that over the internet. But as far as the payroll protection program, you have to go to a bank. And so the problem with that is that not all the banks are ready and available to do this yet. Citibank, for example, as of an hour ago, still was not ready for this. So if you get off the phone, go online, you can look all these things up. And if you have a company, remember, this money is going to run out. So you want to make sure that you either qualify or you don't, and you can get your application in. And we're going to talk about the contingencies on this money and on that loan. And it's supposed to be, the money's supposed to be going out in a week or so. Okay. So what is this money for? You know, so if you're going to apply for the PPP loan, it will be forgiven if the money that you get is used for these purposes. And you need to really document appropriately, and you really have to focus on the fact that you need to make sure you have all your ducks lined up for an audit, because they're going to pick people and you're going to get audited with this. And this is what you can use your money for. Your payroll costs, your health insurance benefits, the employee salaries. A key note is that it only is up to $100,000. So salaries up to that amount are covered. Anything over the more than that, they're not paying anything for. Rent, and then mortgage interests, not principal. It's mortgage interests, your utilities, and any interest on other debt you may have, like C-arms or anything like that. And again, you have to be prepared for an audit, and then you're going to have to apply for forgiveness. This is all just continuation on the law. All right, so the PPP, this is a loan for small businesses of up to 500 employees. It could be anything from a nonprofit to a sole proprietor to an independent contractor, and other people that may be self-employed that are paying taxes. So who would fall in here? It probably that would have anything to do with this that's listening would be, say, a per diem anesthesiologist or anyone you really 1099. So those people, if you do that, you know, you can apply for this potentially too. And there's $350 billion going out with this thing, which is a lot of money. We talked about this, what the money can be used for. Again, it's really all about employee salaries, and we're going to talk about what happens if you don't keep your employee roll up. Really, and the main thing is that the people that are excluded is anything over $100,000. So this is how they calculate how much money you're going to receive or you can apply for. Essentially, you're going to take your payroll over a year. You're going to take your payroll, and then what your payroll would have been over that time, you are going to multiply by 2.5. Essentially, the only difference than your regular payroll than this is that any physicians, most likely, or highly compensated employees, most mid-level practitioners are going to be capped. So it's not going to equal your payroll, but whatever it is, minus that amount that's over $100,000. And the cap of this thing is $10 million, which is, I don't think anybody's reaching out. Essentially, the requirement is, you know, you have to be honest, you have to, you know, have good intention, and that you understand this is because of what's going on in society. As far as being a borrower, your company or your corporation has to be set up before February 15th of this year. And that's obviously important. I just spoke to one of my colleagues who made a real estate investment and started his corporation on March 6th, and unfortunately, he's not going to qualify for this. Or anyone that owes money on their taxes or paid independent contractors. All right.
So Ken, we are actually running out of time. We have many questions, but let me ask you one question. You have a group of 5 physicians, and out of 5, 3 are not really doing anything because they cannot. How would you handle them? Would you still continue paying them? Would you ask them to take a leave, or how would you handle that?
Well, now that this, I think it puts any owner in a tough position because ultimately, you know, we're running small businesses, and we're doing our part in the economy to help things go. But in this situation, it really is tough, you know, because we need to pay the bills, and you know, it really it makes it tough. That being said, even if they aren't doing well, it depends what their contract states. If they're, you know, because most physicians, most of the contracts are very standard, and you know, you can get out, but there's a 60-day period in there where they have to stay on the job. So most likely you would have to pay them for 60 days anyways. I mean, I guess if you're looking to get rid of a person, you can consider it, but you know, that there's legal ramifications involved as well. So I think it would be hard it wouldn't be an easy thing to just get rid of someone.
I think you really covered very well, because it's not an easy situation. And based on a contract, if somebody is on, you know, what you make is what you get type of situation, that makes easier. But if somebody is on 100% payroll, then it's really difficult. But thank you for your presentation. It was very well done, very well covered. Now, if Michelle, all the speakers are available for the question answer.
Yes, everyone can activate your microphone.
I also would like to announce to all of our viewers that we have a Christy Davis. She will take the question if you have anything regarding the business. Just as an introduction of Christy Davis, I'm sure you must have heard her multiple times. She speaks mainly at the regenerative medicine conferences. She is a widely very well accepted speaker all over the country and internationally. And Christy, thank you for joining us. So if I have any questions that is directed to you, I will ask you. But this question is for Adam. The question is, let me just go back to the question. The question is, how about the reduced office from 8 hours to 4 hours? An employee still eligible for 40 hours unemployment?
So unemployment, certainly one thing you don't want to do is promise your employees that they're going to get unemployment or they're going to get a certain amount of unemployment. That's a decision up to the state. I'll tell you right now what's happened is under the CARES Act, the federal government has augmented unemployment by adding an extra $600 a week and an additional 13 weeks to unemployment. Typically, New York State, the maximum was $525. So you have people who can now go on unemployment. If they get full unemployment, it's like $1,100 a week, a little more. You can't, if you reduce their hours, recommend to that employee to go apply for unemployment. You have no concept of how much they're going to get. They will apply, they will notify unemployment, their hours have been reduced, for example, from 40 to 20, and unemployment may assist in filling in that gap. And you as the employer should not challenge that employment. That's really the only thing you can say to them. I will not challenge your unemployment, go ahead and apply. But the relationship in terms of what they get and how they get it is between them and the state of New York, not with the employer.
And do you need to inform the state in advance?
No, you as the employer do not need to do anything. That individual, you can get them information if you want to do that. You can give them the information from the New York State Department of Labor website. Call me, I can get you that information, or you go online and find it, share that with your employee, and then it's up to them to go ahead and apply. You really have no role in that process unless you wanted to challenge that unemployment. You know, in normal times, an employee would resign and you as the employer would get a notice in the mail and you'd say, that's not right. They don't get unemployment because they resign, and you would challenge it. And then maybe they don't get it. In this case, you want people to get unemployment. You're not going to challenge it. In all likelihood, they will get it.
Now I have a question for Christy. I know you are very involved with regenerative medicine. Here, you know, it's a cash payment and patient may not be able to pay, but they really want to have some bone marrow or PRP. How do you think we should handle in this situation where either people don't have money or people are afraid of because of infection?
Well, that's a tough one. You know, first of all, it does depend on where you are in the country to know if you have a place that's obviously safe and equipped to do the procedure. And you know, I've been talking to doctors on a daily basis from 8 till faint for the most part on how they deal with and handle their patients that are struggling to pay. And, you know, we always kind of come back to the first role is to take care of the patient the best way they possibly can. I know a lot of doctors that are working with patients on different types of payment plans. And this goes not just for regenerative medicine, but any type of care. That if this is the best option for your patient and it keeps them out of the emergency room, where we certainly don't want people right now, the nurses and doctors, I'm sure would all agree that they don't need any more people walking into the ER, then, you know, that, and if it's an option that you can afford to do and then take payments or waive the payment, then, you know, that's certainly a business decision that you need to make. But, you know, I know some places are totally shut down. There's no ability to do any procedure. So it does depend on where you're at first, of course.
Absolutely. Thank you. Thank you very much for this, your answer. This question is for Neha. If I am immune to COVID-19 for positive for antibodies, can I still spread the virus? His microphone is not on.
Sorry. It usually depends on symptoms. So basically, if somebody has had the disease and has gotten over their symptoms and has now antibody positive, they should not be able to spread the disease. At this point, though, with COVID, we are not sure if you can be reinfected. So we're not sure at this point if the virus, given how quickly it mutates, will cause a reinfection in the population. So that's questionable. but at this point, it's safe to say if you're 72 hours without fever and without symptoms, you can be exposed to people around you.
Thank you. Now, this question is for anyone of maybe Ken. What about 1099? For example, if I have a billing company that I use, but they are not my employee, so how do you pay them?
So would they be eligible for the loan? So I would say that is more of an expense. And then obviously I'm not a lawyer, and we should probably ask Adam. But I would say that no, a billing company doesn't count as a 1099 employee. There's certain criteria you have to meet that are pretty strict to be a 1099.
Do you mean W-2? If they are not on W-2, they don't qualify?
Even to be, so again, an example of a 1099 would be a per diem anesthesiologist. But whereas the billing company would be an expense. So I would say no, that doesn't qualify as 1099. Adam?
Yeah, I agree with Ken that you know, if you have a vendor, that's not going to be calculated in the loan application. That's not going to be calculated in your forgiveness calculation either. So it's really only employee, rent, mortgage interest, utilities. That's it.
Right.
The next question, thank you, Adam. The next question is actually quite interesting, and anyone could answer, maybe Christy, maybe Dr. Durkin. This comes from likely a paying fellow. The problem is, you know, right now, two situations, because they are short of training 3 months. By the time they will finish, they have 3 months short of their training. So issue is, if some practice have offered them job, but their practice is running into economical crisis and they cannot hire any more physicians. That's number one issue. And number two, how does fellow handle that situation, that now that a job that she or he had, they don't have a job anymore?
It's a good question. I was in the process of hiring people for this year coming up, and that really got waylaid because we're just trying to you know, keep ourselves busy, and it's going to take a while to get back to where we are in hiring mode again. But yeah, I feel rough. It's rough for the fellows. It's a tough time for them. I'm sure they won't have a hard time getting a job in medicine, but it may be a delay in getting into an interventional pain job. But I'll tell you, I think these fellows these days are really well equipped nowadays with the fellowships. Keep getting them ready to practice, even though they have.
Adam, any more tips?
Yeah, I mean, look, if they were offered a job but there's no contract signed, there's no agreement. There is an issue from the employer side that if you have contracts out there and people have signed them and you don't have what's known as a force majeure clause that says I get to terminate this contract because of an unforeseen circumstance like a worldwide pandemic, that the employer may be bound by that contract. And what we're anticipating, especially with large practices, is a lot of lawsuits flowing out of that. Now, there's some case law that says if a contract is impossible or impracticable to perform, they may be relieved from that. So there's not a lot you can do. And if you're on the employee side, I mean, you can't force them to hire you at this point unless you want to get a lawyer and try to enforce that. But that's not a great way to start a relationship with your employer.
Now, Ken, you are looking for somebody, and this new fellow who was supposed to finish his training in June, and now 3 months has no training. So he's short trained. Would you hire him? How would you support him?
Are you asking me if we're stuck with our fellow that we hired?
Yes.
Well, if you're watching Ajax, well, we look to honor our commitments. So, if as long as we're still open, we're gonna honor the agreements that we've made.
As a former program director, I always like to support our fellows. And I think this is the time where we should offer our help to them, because there is not that fault that couple of months, 3 months, they could not, have some training. And, honestly, the initial, even if you are coming from a very well-trained program, the initial few months, you always have to learn something. So I think for us, those who are successful running practices, maybe this is the time to be extra nice to new fellows when you offer them the job. Now we are almost running out of time. I just want to tell our viewers that this last slide has my email address and Sandra's email address. Please feel free to continue sending your questions. We will be very happy to respond to you. This is our first webinar. I hope we were able to bring in some new message to you. It is very tough time. This is a mandatory pause. Maybe this is the time to reflect on our families, friends, and look around to be grateful about. And I think we will all get through. This is, we are all in it together. So it's not like one area or one place is hit hard than the other. So we all pray that this ends soon. We all stick together, try to help each other. And I would like to thank you, panel, for your time. And everybody did an excellent job. Thank you very much. And stay tuned for next webinar. We don't know when, but we will come up with something. Thank you, everybody.
Thank
Stay
you, guys.
safe.
Bye.
Good job, guys.
Yeah, guys, great job.
Yeah, I think a little bit more time for a speaker would be good, but I thought it was great.
Yeah, that was a super rush, man. Holy cow. But hopefully they enjoyed it.
So most of the questions were, financial, labor related, not as much clinical as I thought.
Yeah, I agree. Actually, yeah, there weren't even really that many questions, to tell you the truth. I think you probably answered the ones people had, which, the steroid question and then the when to do injections question. So maybe they left satisfied.
Now, how did the number of people signed on progress over the hour, Michelle? Did it keep up or did people drop off?
I saw at the end there were like 130, 140 people on, like at the very end.
Yeah.
What did they start with?
180. It was 180.
That's pretty good. I got a lot of good feedback on my text messages.
Yeah.
Well, all right, guys, listen, it was a lot of fun.
All right, you guys take care of yourself.
Talk to you later, guys. Bye.
Hello,
Bye.
everybody.
Have a good weekend. Bye.
Bye, Sandra.